Hi everyone, my name is Dr. Shailesh Gupta. I'm a laparoscopic bariatric and robotic surgeon from Max Perpurganj, Delhi. I welcome you all to our lecture series Mastering Bailey Insemination Page by Page. Today I'm going to discuss about shock. This lecture is divided into two parts, and part 2 will be done on Tuesday, and today I'm going to discuss about part 1. So shock is a very important topic. Shock is one of the life-threatening condition and it required life-saving measure for which you should know this topic A to Z, right? This will be going to be a most common clinical condition which you will encounter in an emergency, and you should know every aspect of it so that you can save a life. So as I told earlier, my lecture is centered around page by page text from Bailey and Seviston, and we have simplified the text, emphasized the important points, and we have objectively presented the figure, table and boxes. Before that, there will be some MCQs in the form of pre-test. So the purpose of MCQs is to generate the interest in the text. It is not a MCQ based discussion, and the answer of MCQs you can found in the text, and also it will be given formally in the form of post-test. So today I am going to discuss about pathophysiology of shock in a cellular, microvascular and systemic pattern. And I'm also going to discuss about ischemia reperfusion syndrome. We're going to discuss about classification of shock, severity of shock, and consequences of shock. And I'm also going to discuss about resuscitation, in which conduct of resuscitation, fluid therapy, and dynamic fluid response will be discussed. The rest part of treatment will be discussed in the part 2. So what is shock? Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration, right? It is a state of low tissue perfusion that is inadequate for normal cellular respiration. Just remember these 2 points: low tissue perfusion, which is inadequate for normal cellular respiration. So now I am going to discuss about pathophysiology. First, there will be some MCQs in the form of pre-test. Question number 1. What occurs when glucose within the cell is exhausted during anaerobic respiration? Sodium potassium pump activation, potassium hydrogen pump failure, failure of sodium potassium pump, none of the above. Question number 2. What contributes to tissue edema during the progression of the tissue ischemia? Lactic acidosis, activation of endothelial cell, decreased cytokine release, extracellular water and salt retention. Question number 3. Which of the following is seen in shock? Compensatory respiratory alkalosis, metabolic alkalosis, systemic metabolic acidosis, both A and C. Question number 4. What is the consequence of acid and potassium load that build up during the period of systemic hyperperfusion in ischemia reperfusion syndrome? Direct myocardial depression, vasoconstriction, decreased neutrophil activation, and none of the above. So now I am going to start the theory. First, I am going to discuss about pathophysiology of shock, which is happening at the cellular level. So as we discuss, shock lead to decreased tissue perfusion. So because of decreased perfusion, there will be less oxygen. Because of less oxygen, there will be a start of anaerobic respiration. And as we know that anaerobic respiration lead to lactic acid formation, and because of accumulation of lactic acid, there will be a metabolic acidosis. Guys, so it is very simple, right? So apart from deprivation of oxygen, low tissue perfusion also lead to exhaustion of glucose, right? So as soon as glucose get exhausted, anaerobic respiration gets stopped. So because of stoppage of anaerobic respiration, the sodium potassium pump get failed. So sodium potassium pump at the level of cellular membrane and intracellular organelles, at these both the site, the sodium potassium pump fails. So this leads to lysozyme getting broken down and releasing it autodigestive enzymes. So this autodigestive enzymes leads to lysis of cells, which leads to release of intracellular content into the blood, And the most important component is potassium. Just remember this, right? So, moving on to what is the pathophysiology of shock at the microvascular level? It is seen that tissue ischemia, which has happened due to shock, leads to acidosis and hypoxia. So, both these factors activate the immune and coagulation system. So, it is seen that humoral and cellular component get built up in tissue. So, these humoral and cellular component of immune and coagulation system lead to endothelial injury. And it is seen that endothelial injury further going to activate immune and coagulation system again. So, this is a vicious cycle, right? When the endothelium injury happen, the endothelium become leaky and this leads to extravasation of fluid and cellular component, right? And fluid and cellular component. This leads to tissue edema, and it is seen that tissue edema further causes tissue ischemia, right? So, it is seen that tissue hypoxia leads to activation of immune and coagulation system, which leads to endothelial injury, and endothelial injury lead to tissue edema, and tissue edema further causes ischemia. So, now I am going to discuss about pathophysiology of shock that is happening at the CVS level, right? Because of shock, there will be decreased preload and afterload, and this will going to activate the baroreceptors. Activation of baroreceptor will lead to increased sympathetic activity, and this will lead to increased catecholamines. These increased catecholamines leads to tachycardia and systemic vasoconstriction. Just remember, my friends, there is one exception in this. In sepsis, this doesn't happen like this. Sepsis, there is a vasodilation. It is a kind of a distributic shock. So, there will be vasodilation. There will be decrease in systemic vascular resistance, right? So, sepsis is exception in this. So, what is the pathophysiology at the level of respiratory system? Shock leads to metabolic acidosis because of accumulation of lactic acid, right? So, it leads to metabolic acidosis. It also leads to increased sympathetic response because of decrease in preload and afterload, right? So, because of these two factors, metabolic acidosis and increased sympathetic response, it leads to increased respiratory rate as tachypnea and increase in minute ventilation. So, both these factors leads to washout of the carbon dioxide from the body, and this leads to compensatory respiratory alkalosis. Please remember this. So, two things are happening: metabolic acidosis happening and compensatory respiratory alkalosis is happening, right? So, what is the pathophysiology at the renal level? Shock leads to decreased perfusion pressure in the kidney. This leads to decreased GFR and urine output, and this leads to activation of RAS system, and because of activation of RAS system, it leads to vasoconstriction and increase renal sodium and water resorption. Very common. Due to the effect of angiotensin and aldosterone, there is a vasoconstriction and there is an increased renal sodium and water resorption. So, now what is the pathophysiology of shock at the endocrine level? It is seen that shock leads to activation of adrenal and the RAS system, right? Renin, angiotensin, aldosterone system, and ADH is also released from the hypothalamus. Along with that, adrenal cortex also release cortisol. So, both these three leads to vasoconstriction and resorption of water and sodium in the renal collecting system, right? Just remember this. This is the what happening at the endocrine level. There is the activation of adrenal and the RAS system. There is the release of ADH and there is the release of cortisol. All these three leads to vasoconstriction and resorption of water and sodium in the collecting system. So, now comes a very important topic, ischemia reperfusion syndrome. Guys, it is very important to know about this topic because you're going to face you're going to see lot of patients with this syndrome, right? and it is important to know about this so that you can avoid that, right? So, what is happening in the ischemia reperfusion syndrome? There is systemic hyperperfusion due to shock. So, because of this, there is a tissue hypoxia and inflammation. So, this leads to cellular and organ damage, right? This is very obvious. So, whenever this hypoxic tissue get reperfused, this leads to acid and potassium load in the circulation. So, because of cellular and organ damage, there is a local accumulation of acid and potassium. So, whenever these damaged tissue, these ischemic tissue get reperfused, their local load of potassium and hydrogen ions get circulated in the main circulation. It enter into the main circulation. Because of entering into the main circulation, it leads to myocardial depression, vascular dilatation and hypotension. So, all these factors will going to do more systemic injury, right? So, injury at first instance was local. There was some tissue which were hyperperfused. So, but their load got entered into the circulation, potassium and hydrogen. So, that leads to systemic damage in the form of myocardial depression, vascular dilatation and hypotension. So, further explaining about ischemia reperfusion syndrome, it is seen that hypoxia because of low tissue perfusion leads to activated cellular and humoral components, which are complements, neutrophils and microvascular thrombi. Basically, these are the pro-inflammatory markers, or these are signs of pro-inflammation. So, these components at a time of reperfusion get flushed into the circulation, and this cause endothelial injury to organs like lung and kidney. And as we know that endothelial injury causes tissue edema and other kind of complication, so that it leads to acute lung and renal injury, multi-organ failure and even death. So, guys, it is very important we know about this disease so that we can avoid it. So, it is seen that reperfusion injury can only be attenuated by reducing the extent and duration of tissue hyperperfusion. So, to avoid this syndrome, you need to better manage the shock, right? If you better manage the shock, you can avoid this, right? So, now I am going to give the answer of pretest. Question number 1 answer is choice C, failure of sodium and potassium pump. So, whenever the glucose gets exhausted during anaerobic respiration gets ceases and sodium potassium pump fails. This leads to release of autoreactive enzymes and cell lysis happens. Question number 2 answer is activation of endothelial cell. So, endothelial cell activation leads to tissue edema during the progression of tissue ischemia. Question number 3, which of the following is seen in shock? Answer is D. Compensatory respiratory alkalosis happened because of carbon dioxide washout, right? And this is happening because of lactic acid accumulation. So, answer is both A and C. Answer of question number 4 is direct myocardial depression, right? So, direct myocardial depression is a consequence of acid and potassium load that build up during the systemic hyperperfusion in ischemic reperfusion syndrome. So, guys, I am going to discuss about classification of shock. So, we are going to discuss about some MCQs first. So, what characterize cardiogenic shock? Question choice number 1, decreased systemic vascular resistance. B, elevated preload due to cardiac filling obstruction. C, primary heart failure leading to inadequate tissue perfusion. D, vascular dilatation with hypotension. I would request the students they can type the answer in the chat box. This will going to make the process more interactive. So, question number 2, what characterize the CVS response in distributic shock? High systemic vascular resistance, decreased cardiac output, vasoconstriction with elevated afterload and vascular dilatation with hypotension. Question number 3, what can hypothyroidism cause in terms of shock? High output cardiac failure, neurogenic shock, distributive shock. Choice D, none of the above. Question number 4, how does adrenal insufficiency contribute to shock? Decreased response to catecholamines, hypovolemia, enhanced cardiac output. Choice number D, both A and B. So classification of shock. Please remember this. This classification is based on the initiating mechanism, right? And all types of shock have systemic tissue hyperperfusion, and different type of shock may coexist in the same time in a same patient, right? So shock is divided into hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and endocrine shock, right? So now I am going to discuss about hypovolemic shock. So hypovolemia is the most common form of shock. Please remember, this is the most common form of shock, and in most cases is a component of all other form of the shock. This is a very important point. In most cases is a component of all other form of shock, right? So hypovolemia may be hemorrhagic or non-hemorrhagic. The examples of non-hemorrhagic are dehydration, vomiting, diarrhea, and the loss through the urine. And there could be third space loss in the form of like in case of bowel obstruction, there will be a bowel edema, fluid loss in the GIT, and also in the interstitial space in pancreatitis. So now, what is cardiogenic shock? So it is the failure of the heart to pump blood to the tissue. So the problem is happening at the level of heart, right? So causes are MI, cardiac dysarrhythmias, valvular disease, blunt MI, blunt myocardial injury, and cardiomyopathy. So it is seen that in the case of sepsis, endogenous factors like bacterial toxins and humoral agents or drug abuse can also lead to cardiogenic shock, right? So these are also other factors which can damage the heart. Endogenous factor from the bacterial wall or bacterial toxin, humoral agents can or drug abuse can also damage the heart. So because of cardiogenic shock, heart will not able to pump the blood, so there will be back pressure changes. It will lead to venous hypertension with pulmonary or systemic edema. So these are the sign of basically cardiac failure. So in case of cardiogenic shock, you are going to see venous hypertension with pulmonary or systemic edema. So what is obstructive shock? Obstructive shock is decreased preload due to mechanical obstruction of cardiac filling. So here the right or left chamber of heart is not able to get filled with blood because there is some mechanical obstruction over it. So because of improper filling or less filling, there is a decreased preload, right? What are the causes? Cause could be cardiac tamponade, tension pneumothorax, massive pulmonary embolism. So all these factors will lead to improper cardiac filling. So this is a very important shock and little complex also, distributive shock. So what we found in distributive shock, it is seen that distributive shock is also a low organ perfusion state in which there is a vascular dilatation with hypotension, right? So vascular dilatation is a unique point, right? Along with that, it is seen that there is a low systemic vascular resistance, there is an inadequate afterload, and there is an abnormally high cardiac output. Why the cardiac output is high? Because afterload is less, there is a decreased systemic vascular resistance. So because of decreased afterload and decreased systemic vascular resistance, there is a abnormally high cardiac output. I hope guys this slide is very clear. So distributive shock is seen in three states. It is a part of sepsis, septic shock, it is a part of anaphylaxis, it is a part of spinal cord injury. So what happening at spinal cord injury? There is a decrease in sympathetic outflow. But remember my friend, vascular tone is normal. So this is basically a neurogenic shock, right? Spinal cord injury leads to neurogenic shock. There is a decreased sympathetic outflow, but vascular tone is normal. So what happening is anaphylaxis, it leads to release of histamine, and this leads to vasodilatation. And my dear friend, in septic shock, there is a, because of endotoxin, cellular and humoral components, there is a vasodilatation along with decreased systemic vascular resistance. So this all leads to distributive shock, right? It is important that initially septic shock behave like a distributive shock, but in later phase of septic shock, there will be hypovolemia with concomitant myocardial depression, complicating the clinical picture. So why the myocardial depression is happening? Because these toxins, cellular humoral component, are directly depressing the myocardium. So septic shock is a little kind of a complex shock which have 2 to 3 layers in it, right? It will have going to have a hypovolemia, it going to have a component of cardiogenic shock also, and obviously it going to have a distributive shock component also. So these are the 3 ways in which a distributive shock can present. So moving on to the endocrine shock, it is a combination of hypovolemic, cardiogenic and distributive shock. So there are 3 conditions in which we can see this. So hyperthyroidism can give rise to endocrine shock because hyperthyroidism leads to disorder vascular and cardiac response to circulating catecholamines. So vessels and heart will not going to interact with catecholamine in a normal way. So this leads to decreased inotropy and bradycardia, which in turn lead to decreased cardiac output, right? So in a kind of way, hypothyroidism mimic a neurogenic shock, right? Because in neurogenic shock there was a decreased sympathetic outflow. So hypothyroidism is also giving rise to a similar kind of a picture, right? So it is seen that apart from this, hypothyroidism also causes cardiomyopathy, right? Which can also lead to shock, basically a cardiogenic shock, right? So it is seen that in hyperthyroidism there is a high output cardiac failure, right? And this is basically a cardiogenic shock, right? I hope guys I am clear. Now you know about endocrine shock, right? There is another component of endocrine shock, that is adrenal insufficiency. Adrenal insufficiency can also cause endocrine shock. How it causes? It causes hypovolemia and it also causes decreased response to catecholamine. That is how it causes shock, right? And it is seen in Addison disease and sepsis. So my dear friends, just remember 3 things in endocrine shock: hyperthyroidism, hyperthyroidism and adrenal insufficiency. Hyperthyroidism give rise to a picture kind of a neurogenic shock and it will also lead to cardiomyopathy. Hyperthyroidism leads to high output cardiac failure, will give rise to cardiogenic shock, and in case of adrenal insufficiency there will be hypovolemia and there will also be decreased response to catecholamines, giving rise to a shock. So here guys we are seeing a table which I have taken from the Bailey. So here we can see that there are certain cardiovascular and metabolic characteristic of different type of shock. It is seen that cardiac output is low in all type of shock except distributive shock. It is high, right? Just remember this, cardiac output is high in the distributive shock. And just remember also, vascular resistance is high in each shock except in distributive, in distributive it is low. This is because of vasodilation which is happening in distributing shock, right? Again, the base deficit is high in all because basically it is a low tissue perfusion state, right? And it is seen that venous pressure is high in cardiogenic and obstructive shock, and it is low in the hypovolemic and distributive, because in cardiogenic and obstructive shock there is a failure of pumping mechanism of heart. Heart is not able to pump the blood. So this is leading to high venous pressure. So going on to the post test, the answer of question number 1 is choice C. Primary heart failure leads to inadequate tissue perfusion, and this characterizes the cardiogenic shock. The answer of question number 2 is choice number D. So vascular dilatation with hypotension characterize the cardiovascular response in distributive shock. Answer of question number 3 is neurogenic shock. So hypothyroidism usually mimics a neurogenic shock. So answer of question number 4 is how does adrenal insufficiency contribute to shock? Answer is it decreases the response to catecholamines and also it leads to hypovolemia. So answer is choice number D, both A and B. So now guys, I am going to discuss about severity of a shock. So few questions before that. What are the clinical signs of compensatory shock? Normal pulse, cool periphery, cyanosis, hypotension. Question number 2, what is the systemic manifestation of compensatory shock? Normal blood pH, metabolic acidosis, respiratory alkalosis, hyponatremia. Question number 3, at what percentage of circulating blood volume loss are normal compensatory mechanism get overloaded? 5%, 15%, 30%, 50%. So what is compensatory shock? It is seen that in the initial phase of shock, there are certain compensatory response from the cardiovascular system and endocrine system which leads to decreased flow to non-essential organ, which are basically skin, GIT and muscle. And basically there is shunting of blood to the essential organs like kidney, lung and brain. So at this compensatory shock, there will be only tachycardia and cool periphery, and there will be no other clinical sign of hypovolemia. So just remember guys, this is a compensatory state of shock. Here we are going to only see tachycardia and cool periphery, there will be no other sign. And basically compensatory shock is a state of occult hypoperfusion in which metabolic acid will be there, but urine output and other serious sign will be normal. So just remember that state of acute hypoperfusion. It is seen that in compensatory shock, the organs in which there is a less perfusion, that is skin, GI tract and muscle, there is a increased load of humoral and cellular elements, and because of release of lactic acid from these organs, this leads to systemic metabolic acidosis, right? So whenever these underperfused segments get reperfused, it will lead to ischemia reperfusion effect, and this will lead to multi-organ dysfunction. I have already discussed the mechanism of this injury in the previous slide, and it is seen that if compensatory shock remain for more than 12 hours, it will lead to increased mortality, increased infection and increased chances of multi-organ dysfunction. So we have discussed the compensated. I am going to discuss about decompensatory shock. It is seen that when there is a loss of greater than 15% of the blood volume, there will be a decompensatory shock. And it is seen that BP only fall when the more than 30 to 40% of circulating volume has lost. This is very important. BP doesn't fall in the initial stage of shock. It only fall when more than 30 to 40% of circulating volume has been lost. So decompensatory shock can be divided into mild, moderate and severe shock, right? So this is a table taken from Bailey. So this describe all type of shock, compensated and decompensated. So mild, moderate, severe shock are a kind of a decompensated shock. So here are the comparison of various parameters, biochemical, respiratory and CVS parameter. It is seen that lactic acidosis is present in all four of type of shock, but it is less in compensated and it is more in the severe form of shock. This is very obvious, right? So urine output remain normal in compensated and mild, but it reduce in moderate, and patient can also become anuric in severe shock, right? Consciousness level, it remain normal in compensated. There could be a mild anxiety in mild. There patient is drowsy in moderate, and patient is comatose in severe form of shock. Respiratory level in compensated shock, the respiratory rate will be normal. It will be increased in mild and moderate, and there will be a labored breathing in severe. And in pulse rate, tachycardia is present in all the four forms. There will be mild increase in pulse rate in compensated, and there will be a greater increase in severe form. So this is a very important point, BP. So it is seen that BP behave normally in compensated and mild shock, whereas it get lowered in moderate and severe. So just remember that normal BP doesn't mean patient do not have a shock, because BP is the last parameter to get dearranged. Just remember this. So I'm going to discuss about pitfalls in clinical science. So there are certain clinical signs of CVS system which help us to diagnose the shock. But these clinical signs have some errors, right? They are not accurate, they are quite variable, and in some patient and in some clinical condition, their interpretation can be faulty. For example, capillary refill time. It is seen that hypovolemia leads to increased capillary refill time, but we should know that capillary refill is a variable factor and non-specific factor for shock. Normal value varies from person to person, and it is seen that capillary refill time could be shorter in early stage of shock. Just remember this. And in case of septic shock, there could be a brisk capillary refill. Why? Because of vasodilatation. Just remember this. Another inaccurate factor is tachycardia. So it is not always necessary. Tachycardia will always be present in the shock. There could be some state in which normal pulse rate also points toward the shock. For example, patient taking beta blocker or patient who have pacemaker in C2 will not able to produce tachycardia in response to shock, number one. And there is a paradoxical bradycardia which is seen in severe and prompt hemorrhage. Like in a condition in which there is a severe hemorrhage in a very short time, patient can present in a form of bradycardia, which is basically a paradoxical bradycardia. Young athlete who have a pulse rate of 50 in a case of shock might present with a pulse rate of 80, which itself is a normal pulse rate, but they have a shock. So tachycardia is not always associated with the shock, right? So another one inaccurate measure is BP. So it is important to know that hypotension is the last sign of shock, right? And in children and young adults, they are able to maintain the BP till the last stage of shock by virtue of they are able to increase the stroke volume, and also they are able to increase vasoconstriction. So by these two mechanisms, they are able to maintain the BP till the last stages of shock. And it is important to know that hypertensive elderly after a shock may present with a normal BP reading, right, which could be a normal reading for general population, but for them it is basically a hypovolemia state. So now the post test, what are the clinical signs of compulsory shock? Answer is cool periphery, right? What is the systemic manifestation of compulsory shock? Answer is metabolic acidosis. Respiratory acidosis is also seen in the shock, but in compulsory shock there will be only metabolic acidosis, right? So moving on, answer of question number 3, at what percentage of circulatory blood volume loss or normal compensatory mechanism get overloaded? Answer is 15%. So till the 15% compensation can be done. Beyond the 15%, shock become decompensated. So what are the consequences of shock? So these are the pre-test. What happens peripherally during prolonged profound shock? Formation of superficial skin ulcer, enhanced responsiveness to vasopressor agent, loss of the ability to maintain systemic vascular resistance, and choice D, loss of pain sensitivity. What is the current mortality rate associated with the multi-organ failure? 30%, 40%, 50 and 60%. So guys, I'm going to discuss about unresistable shock. So unresistable shock is basically happen when profound shock or a severe shock remain for a longer time. Okay. So in this, the ischemia leads to cell death and there is a severe myocardial depression and myocardium become non-responsive to fluid or inotrope. This is very important. And along with myocardium, peripheries are also non-responsive to vasopressor agent. So this is very important. Basically, it is a non-responsive clinical condition. Just remember that, non-responsive. Right? This is inevitable in this late stage. Minimal response is there to a maximal therapy. Just remember this line. Body will have a minimal response to maximum therapy and myocardium and peripheral vascular system is non-responsive to fluid or inotropes, right? So the next consequence of the shock is multiple organ failure, right? So it is seen that with the advance in the resuscitation technique, the survival has increased, but because of the prolonged systemic ischemia and reperfusion injury, the shock can result in end organ damage and also can lead to multiple organ failure. Multiple organ failure mean when two or more organs are impacted, right? The treatment is basically supportive in the form of inotropes, in the form of ventilator, in the form of dialysis. So basically there is a supportive treatment only, right? And it is known that with a multi-organ failure, there is a chance of 60% mortality. So now in the post-test, I am going to discuss about the answer. This is basically post-test. The answer of question number one is loss of ability to maintain systemic vascular resistance. This usually happen in the periphery during prolonged profound shock. Answer of question number 2 is 60%. 60% is the current mortality rate associated with the multiple organ failure. Now, I am going to discuss about a very important treatment part, that is resuscitation. So, these are the pre-test. What is the recommended approach if there is an initial doubt about the cause of the shock? Get investigation for definitive diagnosis done. Assume the cause is hypovolemia and initiate the fluid resuscitation. Administered antibiotic immediately to cover sepsis. Choice number D, none of the above. What the volume of fluid is typically administered in a rapid bolus during the assessment of shock status? 100 to 150 ml, 200 to 250 ml, 250 to 500 ml and 600 to 800 ml. I will request the students to type their answer in chat box, please. Question number 3, administrating inotropic or conotropic agent in the absence of adequate preload can lead to reduced diastolic feeling, reduce myocardial oxygen stores and decrease coronary perfusion, and choice number D, all of the above. So, priority of immediate resuscitation in shock is to ensure patent airway and adequate oxygenation and ventilation. So, this is basically a very basic of ATLS and CRISP protocol. We need to maintain A and B before maintaining C. A is for airway, B is for breathing. Then the C will come, then the circulation will come, right? So, after that attention is directed to the CVS resuscitation. So, these are the basic point of conduct of resuscitation. The resuscitation should commence promptly without waiting for a definitive diagnosis of the shock source. This is very important, right? We should not wait for definitive diagnosis. We should start the resuscitation immediately. In case of initial uncertainty about the shock cause, it is safer to assume hypovolemia and initiate fluid resuscitation, then assess the response. For actively bleeding patient, high volume fluid therapy is counterproductive if done without controlling the hemorrhagic site. It is because it can lead to hypertension. Hypertension will lead to more blood loss. And second thing, this high volume fluid therapy will lead to dilution of coagulation factor, which will cause itself more bleeding, right? And whenever the surgery is required to control the hemorrhage, then it should not be delayed, and resuscitation should occur concurrently with surgery. This is very important. This is a very specific point for shock caused by a massive hemorrhage, right? So now the next part is fluid therapy. So it is very important that in all shock cases, we should address the hypovolemia first so that we can maintain the adequate preload. So what is the importance of adequate preload? It is seen that if we are going to give inotrope or conotropic agent on empty heart, it will lead to permanent oxygen myocardial depletion. It will lead to decreased diastolic filling, and it will also lead to decreased coronary perfusion. That is why you need to pump a filled heart. If we are going to pump the empty heart, it will lead to all kind of complication. That is why we need to address hypovolemia first, right? Patient can reach unresuscitable stage if the myocardium become progressively more ischemic and unresponsive to resuscitative attempts, right? So this is very important slide, and this we need to keep in mind while managing the shock patient. So now the discussion about type of fluid. There is no ideal resuscitation fluid, and it is more important to understand how and when to administer IV fluid, right? There is no clear advantage between crystalloid and colloid in shock resuscitation. It is seen that colloids are costlier and have more side effect with minimal volume benefit. That is why, what is minimal volume benefit? For a 1 liter of colloid is equal to 1.3 liter of crystalloid. So basically there is no much volume difference. So volume benefits are also minimal, right? So neither crystalloid and colloid carries oxygen. So blood is the only ideal replacement for the lost blood. Hypertonic solution like dextrose are ineffective volume expander and should be avoided in shock unless specific condition like if there is a free water loss or sodium overload, then only we should give dextrose, otherwise it is of no use. So what is dynamic fluid response? Basically shock status is assessed dynamically through cardiovascular response to a fluid bolus, right? Here we are going to give a fluid bolus and we are going to check the cardiovascular response after it, and according to that we are going to divide the patient into shock status. So in this 250 to 500 ml of fluid is administered rapidly over 5 to 10 minutes, and heart rate, blood pressure and CVS responses are observed, right? Patients are characterized as responders, transition responders or non-responders based on their cardiovascular reaction. So what are the responders? Responders are those in which there is a immediate improvement in the CVS responses which are also sustained. So remember these two, improvement is also there and it is sustained. So these responders are not actively losing fluid but required filling to a normal volume status. So they are not losing fluid, right? Next category is transition responders. Basically they will be a temporary improvement in their CVS responses followed by return to a previous state within next 10 to 20 minutes, right? So improvement is temporary, right? So these patients will have a moderate ongoing fluid losses either in the form of overt hemorrhage or additional fluid shift which leads to decreased intravascular volume, right? So either there could be a hemorrhage or there could be shifting of fluid leading to decreased intravascular volume, right? So the next category is non-responder. They are basically in a severely volume depleted state and they are experiencing significant ongoing losses of intravascular volume, right? And the reason is they have a persistent uncontrolled hemorrhage. So non-responder are basically a category of severe state of shock. So the answer is, answer question number 1 is, this is a post-test. What is the recommended approach if there is an initial doubt about the cause of shock? Assume the cause is hypovolemia and initiate resuscitation, right? This is the answer. We should not search for diagnosis and our resuscitation should start immediately, and if there is no initial cause of shock, we should assume it is hypovolemia and we should start the fluid therapy, right? What is the volume of fluid is typically administered in a rapid bolus during the assessment of shock status? Answer is 250 to 500 ml. And the last question was, administrating inotropic or conotropic agent in the absence of adequate preload can lead to reduced diastolic filling, reduced myocardial oxygen stores, and decreased coronary perfusion. Answer is all of the above. Thank you guys. I hope you like this lecture. It was a very important lecture, so I have covered exhaustively, because shock is a very important topic and we need to know about A to Z. The rest part I am going to cover in the part 2, and now the session is open for question and answer. Thank you so much.